Great, everyone. In the interest of time, I think hopefully we will have a few more people joining us in the coming minutes. But I wanted to begin as we're now officially 2 minutes past and we have quite a bit to pack in over the next 90 minutes. Welcome everyone to this webinar. And just to let you all know that this is being recorded as well as live streamed on YouTube. And we also have for everyone joining us simultaneous English, French, English translations available. And you can do that. You can find the translation button at the bottom either by clicking the 3 buttons that say more and going to the interpretation and selecting the language you'd like to hear and listen to for this webinar today. So thank you everyone for joining us. I am Joanna Rija, the research lead for gender equality and intersectionality at the United Nations University International Institute for Global Health, based in Kuala Lumpur, Malaysia. And it is with immense pleasure that I welcome you all to the launch of this webinar and report today that focuses on a rapid evidence review on gender responsive and transformative interventions in HIV, TB, and malaria programs. I would like to give apologies from our director who could not join us today, and so I will be giving opening remarks in her stead. We're gathered here really to focus on 3 of the world's most persistent public health challenges: HIV, tuberculosis, and malaria. And as all of you know, I'm sure, these diseases continue to cause immense suffering and loss of life, disproportionately affecting the most marginalized and also the poorest populations, including women, girls, and gender diverse communities, especially in low and middle income countries. It is widely recognized that we cannot achieve the global goals of ending HIV, TB, and malaria without advancing health equity, gender equality, and critically, human rights. And just as importantly, programs must ensure that they do no harm. And avoiding reinforcement of existing gender equalities is exactly that. And this is why it is so important as we launch this report today and focus on gender responsive and gender transformative approaches as they challenge harmful social norms, dismantle discriminatory laws and policies, and really address the structural drivers of vulnerability and discrimination. And while progress has been made over the last 3 decades, recent setbacks, as we're all fully aware, including cuts to international aid, geopolitical instability, widening inequalities, which we're seeing for the first time in decades, and the impacts of climate change, are really threatening these hard-won gains. And in this context, building on evidence is now urgent more than ever. Yet despite evidence that has been collated and existing and built on over the last decades, there has been no comprehensive review that has synthesized gender responsive and transformative approaches across HIV, TB, and malaria programs. And strengthening this evidence base is absolutely critical to inform strategies that tackle some of the structural inequalities I described earlier, especially at a time where we face both these extreme funding cuts and pushback and backlash on gender equality and human rights. And so our webinar today marks a launch of an important piece of work to address this exact gap. And led by the Gender Equality and Intersectionality Work Package here at UNU-IIGH, this review really highlights promising practices and lessons learned that can guide more effective program design and implementation. And importantly, it reinforces the need to draw on this existing evidence base to strengthen gender-focused interventions across the 3 disease areas, and not solely rely on biomedical approaches, which risk really exacerbating or reinforcing existing gender inequalities and may ultimately be doing more harm. Being the lead for this project, I wanted to take a moment to also acknowledge and thank all those who have contributed. We have 2 of the fantastic researchers who are part of that who will be presenting more information from the report, but just to acknowledge others who were involved. We'd like to thank Emilomo Ogbe, Teresa Willis, and Michelle Remy for their consistent support over the course of the project, and also thank experts from the World Health Organization Gender Rights and Equity Unit and the Joint United Nations Program on HIV/AIDS, UNAIDS, and Global Fund's experts as well, who have given feedback during various stages of this review. So before I begin, I'm sure you all want to hear from the keynote and also from the fantastic researchers and panelists we have here today. So I'll give you a quick run through of how the webinar will progress. We will have a fantastic keynote address, and we're very honored to have Professor Awa Kolsek with us. This will then be followed by a presentation by members of the research team. And we'll then move to hear from a diverse panel from WHO, the Global Fund, and South Africa's National AIDS Council Civil Society Forum, who will unpack what these findings mean from their perspectives. And finally, we would like to open the floor to questions. So please do keep them coming in the chat, and we will keep a track, and should time allow, hopefully get to some of them. So now, I'm sure this is the part many of you have been waiting for. I have the immense pleasure of introducing our keynote speaker, Professor Awa Kolsek. Professor Kolsek is a leading expert in infectious diseases and bacteriology and virology, holding both an MD and a PhD. Her extensive experience also includes public service as a former senior minister to the President of Senegal, and she now chairs Gallian Africa, where she leads the annual Gallian Forum Africa and the Pre-Gallian Africa. Professor Kolsek has served twice as Minister of Health in Senegal, and she was named Best Minister in the World in Dubai in February 2017 at the World Government Summit. Professor Kolsek was also the Executive Director of Rollback Malaria Partnerships and Director of UNAIDS Policy Strategy and Research Department. At UNU-IIGH, we have the privilege of having Professor Kolsek on our International Advisory Board as well. And her full bio is available in the chat. So now, to kick us off for our keynote, I would like to hand over to Professor Kolsek. Thank you.
Thank you, Joanna. It's a real pleasure for me to be here today. It's an honor. But I will speak in French, and I would love people to use the translation if necessary. Donc, c'est un honneur pour moi d'intervenir dans le cadre de cette rencontre organisée par l'Université des Nations Unies concernant la santé mondiale. C'est un institut de référence du système des Nations Unies et qui est engagé dans la production de connaissances et d'analyses stratégiques au service d'une santé mondiale plus équitable. L'occasion donc est très belle. Il s'agit du lancement d'un rapport consacré aux interventions sensibles au genre et transformatrices du genre dans les programmes VIH, tuberculose et paludisme. Et je sais que cela a été fait en relation notamment avec des institutions internationales comme le Fonds mondial qui appuie les pays concernant ces trois maladies. Je vous remercie donc pour cette invitation. Félicitations à l'équipe de recherche et étant membre du conseil d'administration, je peux certifier de la qualité des personnes qui sont impliqués dans cette recherche et dans les autres recherches. Et je voudrais donc vous féliciter pour cela. Nous avons toutes et tous raison d'être aujourd'hui ici. Et je voudrais dire que les progrès réalisés contre les trois épidémies mondiales sont des progrès réels. Mais ce sont des progrès qui sont également fragiles. Fragile face aux réductions de financement, vous l'avez dit déjà dans l'introduction, fragile face au changement climatique, mais également fragile face à la discrimination, face à la stigmatisation et fragile aussi en raison de l'instabilité géopolitique. On peut dire également qu'un point important et qui n'a pas suffisamment été pris en compte, ce sont les inégalités de genre qui continuent de façonner l'exposition aux risques et l'accès aux soins, mais également aux résultats de santé. Pendant trop longtemps, nous avons pensé que les solutions biomédicales suffiraient. Les médicaments, les diagnostics, les moustiquaires, les vaccins sont essentiels, mais ils ne suffisent pas. On ne peut pas médicaliser la prise en charge d'épidémies ni la sortie d'une crise épidémique. Mais certes, mais il faut savoir que derrière chaque infection, chaque retard diagnostique, chaque rupture de traitement, derrière tout ça, il y a des normes sociales, des rapports de pouvoir, des contraintes économiques et souvent des inégalités entre les femmes et les hommes. Ce rapport arrive donc à ce point nommé. Il nous rappelle que l'évidence scientifique doit guider les investissements pour qu'ils soient plus intelligents, plus équitables et plus durables. Mais que nous disent clairement les données? Les interventions sensibles au genre sont sans ambiguïté. Elles sont transformatrices et elles améliorent les résultats de santé. Ce qui fonctionne le mieux, ce sont les approches multiniveaux, c'est-à-dire il ne faut pas simplement régler le problème au sommet, mais aussi au niveau des communautés, mais également multisectorielles et enfin combinant santé, protection sociale, éducation et autonomisation économique, avec un rôle central qui va être joué et qui est joué d'ailleurs par les communautés et la société civile. À l'inverse, lorsque le genre est ignoré, l'efficacité des programmes est souvent affaiblie. Un exemple simple, travailler avec les hommes et les garçons pour redéfinir la masculinité, non pas comme un déni de la vulnérabilité, mais comme la responsabilité envers soi-même et sa famille et sa communauté. Améliorer le recours aux soins et l'adhésion au traitement. Des leçons concrètes sont tirées du terrain. Les normes de genre façonnent l'accès aux services de santé, l'adhésion aux soins et la confiance envers les systèmes de santé. Les femmes assument souvent leur charge de soins importante sans disposer d'un réel pouvoir de décision. Les hommes peuvent retarder le recours aux soins en raison de la norme de masculinité qui est préjudiciable. La prise en compte des dynamiques de pouvoir renforce la performance des systèmes de santé. Permettez-moi de partager 3 exemples, un pour chaque maladie, parce qu'il y en a tellement et je sais que tout à l'heure, vous aurez beaucoup d'exemples dans la présentation du rapport, mais aussi au niveau du panel. Dans de nombreux contextes, le risque d'infection au VIH des adolescentes et des jeunes femmes est étroitement lié aux violences basées sur le genre, à la dépendance économique, à l'absence du pouvoir de décision. Le partenariat DREAM, à travers son modèle Cash Plus, l'a démontré dans 15 pays africains. Offrir une bourse scolaire ou un petit transfert monétaire à une jeune fille réduit son risque de VIH plus efficacement que n'importe quel discours. Pourquoi cela? Parce que cela lui donne quelque chose d'essentiel, le pouvoir de dire non. Concernant la tuberculose, nous parlons souvent de millions manquants. Ce sont des hommes qui retardent les soins à cause de normes de masculinité néfastes. Les femmes qui subissent la stigmatisation et le retard au diagnostic. Au Nigeria, des approches innovantes testent des sites de diagnostic adaptés aux hommes dans des lieux où ils se trouvent réellement. Par exemple, les marchés, les lieux de travail informels, l'arbre à palabres et d'autres espaces sociaux. Le message est simple mais puissant. Se soigner, c'est rester fort pour sa famille et pour soi-même. Enfin, le paludisme, c'est également un point important. Concernant le paludisme, nous avons là également vraiment une notion qui est la notion de chef de ménage, qui souvent n'est pas la réalité, parce que ce sont les femmes qui gèrent la prévention et le traitement au quotidien. En Éthiopie et au Ghana, l'intégration de l'éducation sur le paludisme dans des groupes féminins de microfinance, cela a produit un résultat remarquable. Lorsque les femmes ont eu le contrôle de petits capitaux, le traitement du paludisme chez l'enfant est devenu 40% plus rapide. Ce n'était pas une question de moustique, c'était une question de pouvoir économique. Quelles sont les lacunes que nous pouvons également observer dans ce rapport? Ce sera détaillé pour plus tard, mais nous disposons d'une base de données probante solide pour le VIH, mais beaucoup plus limitée pour la tuberculose et le paludisme. Parce que nous avons moins investi dans la recherche et l'apprentissage pour ces deux maladies. Mais c'est une opportunité pour renforcer la recherche opérationnelle, mais également investir dans le leadership scientifique local et encourager les échanges sud-sud et interrégionaux. Je voudrais qu'on aille de l'évidence à l'action et conclure par 3 messages clés. Premièrement, élargir et protéger la base de données probante, en particulier pour la tuberculose et le paludisme. Deuxièmement, accompagner les gouvernements afin que ces données se traduisent en politique publique, mais également se traduisent en mise en œuvre concrète. Troisièmement, investir dans le leadership local de la recherche, notamment dans les pays du Sud. Car le message central de ce rapport est clair. Le genre n'est pas optionnel. Il est au cœur de l'équité, de l'efficacité et de la durabilité de nos réponses sanitaires. Au niveau de cette Université des Nations Unies, qui s'occupe de santé mondiale, en tant que membre du board, je peux vous dire que c'est notre engagement et précisément transformer les données probantes en politique et en action au service d'une santé mondiale plus juste. Je vous remercie de votre aimable attention.
Thank you so much, Professor Kosek, for that presentation, for giving such a powerful and disease-by-disease specific examples of the centrality of gender equality, which doesn't just pertain to women and girls, but affects men also. And I think we thank you so much for driving home that message that, you know, gender equality is absolutely central to equity, effectiveness, and sustainability. Thank you once again. I now have the pleasure of turning to 2 researchers who were absolutely critical and foundational in the research and the report that we're launching today. Dr. Anjana Bhushan is an independent consultant who has worked with the World Health Organization for over 24 years, where she has provided technical leadership and evidence-based advice to member states on especially this issue in terms of systematically integrating gender-responsive, equity-enhancing, and human rights-based approaches into health policies and programs. We also have Dr. Sapna Mishra, who is a policy research associate at UNU-IIGH. Sapna holds a PhD in public health, and prior to joining IIGH, she served as a faculty member at a private university in India. So, Sapna and Anjana, over to you. We're really looking forward to hearing, you know, the details from the report. Thank you.
Thanks, Joanna. Kapusin, can we go to the next slide, please? Yes, so I will not take a lot of time here because we have already set the tone. Professor Kolsak and Joanna have explained in detail why do we need to have evidence on gender responsive or transformative interventions when it comes to three diseases. And we are very clear that you cannot achieve or eliminate these diseases without focusing on gender equality, and therefore our review was focused on gender responsive and transformative approaches and not just highlighting what are the gender related issues or just grieving or looking into awareness program or other stuff, because we are very sure that in order to eliminate these diseases you really need to have evidence which talks about challenging the structure, and therefore the need for set of interventions which challenge structure and talk about equality, and the gender lies cross-cuttingly across these three diseases. Next slide, please. Briefly mentioning about why it's a evidence review in terms of rapid review and not a systematic review. So we follow very closely with the methodology of systematic review, but due to time constraints and other resource constraints, we had to rely on a rapid review, which is equally verified methodology of evidence synthesis. Next slide, please. So these were our two broad objectives. We really wanted to synthesize and compile all the evidences, focusing on both gender and health outcomes and not solely on health outcomes, because we are talking about gender responsive and transformative approaches. And the second objective was also to come up set of recommended intervention which should work across all the three diseases, and not again focusing specifically on diseases, because we know the gender works almost in the similar ways in all across three diseases. Next slide, please. So we started with the two search engines, PubMed and Scopus, because we had access to these two, and we additionally we also search into Global Fund website, WHO and Cochrane and other stuff to look for relevant stuff. Additionally, we also contacted experts who have been engaged in the domain of gender responsive and transformative approaches and working in the infectious diseases. And we confine our work to LMICs, because we also know that these diseases heavily impact and disproportionately impact people in LMICs, and we looked into publications from the last 20 years. Again, we had to take the call on setting the time period, so that was the reason. And unfortunately, we had to confine to the English language, which was one of the limitations of the review. And yeah, and we did come up with a data extraction sheet to make sure that we cover everything. Next slide, please. So this was our data extraction template. This is a broader one. We thought of not putting it a detailed one, but we have the detailed data extraction sheet in the report. So please look at there. I just wanted to emphasize again, we looked into these 4 domains, but when it comes to intermediate outcome, we thought it's important again to focus on both disease and gender related outcome, because the entire purpose of the review was to look into gender responsive and transformative approaches, which also ensures that there should be changes in the way gender operates across these 3 diseases. Next slide, please. Next slide, please. So this is a very brief flow chart about how did we go with the review. So we initially obtained 11,844 articles, searching in both the databases. And finally, we reduced it to 42 articles, which also included 6 articles that we got from the experts or looking into other sites, which we did not obtain through PubMed or Scopus. So we had to reduce it to the 42, and we systematically went through the process and finally reviewed 42 articles out of 11,844. Next slide, please. So a very brief descriptive findings from the review. So most of the studies were from Sub-Saharan Africa, if you look into it, and which is again, verified what is there in the literature, that how these 3 diseases are ravaging certain part of the globe. And that's why you get a lot of study from that part, which is Sub-Saharan Africa. When it comes to stages of care pathways, so most of the studies or the interventions in most of the studies focus into the prevention part. But these 5 categories are not mutually exclusive, because there were studies which were focusing on prevention at the same time also on treatment. But then certain studies specifically focus on prevention. Next slide, please. Based on, again, the work which we're doing and trying to make sense of the data, we divided all the interventions against these 5 categories, started with economic empowerment, gender norms changes, whether the intervention strengthened the health system, whether it brought social empowerment, and where they were focusing on changing the legal and the policy norm. So interventions in most of the studies specifically looked into the economic aspect, and so the outcome was mostly empowering communities economically. Next slide, please. Again, when it comes to evaluating an interventional study, we know that mostly the design which is used is randomized control trial or cluster randomized control trial. But interestingly, in our studies, we found randomized control trial and also qualitative studies. So that was also interesting, because when it comes to evaluating intervention, qualitative studies do not get the major attention. But around 11 or 12 of these studies did utilize qualitative study, and the next was by again quasi-experimental studies. If we look into the duration of these interventions, so the interventions which were there for more than 2 years did make better impact, or we had more evidence which says that longer duration intervention fare better than the shorter duration intervention. Next slide, please. Yeah, so now I will hand over to Anjana for detailed presentations of findings. Anjana.
Thank you so much. Thank you so much, Sapna, and greetings, friends. I'm going to try and zip through give you an overview of the key recommendations based on our findings. Next slide, please. So we tried to synthesize some key features of the types of gender responsive or transformative interventions that we found in the evidence, and we're using the term gender focused to include both of these types of interventions. And we found that indeed there were effective gender-focused interventions that brought about improved health-related outcomes. And we're focusing most of this presentation on HIV because, as you saw, a large majority of the studies did relate to HIV. And then I will come to the transferability of this evidence to the other 2 disease areas. But you can see here the types of health outcomes, the intermediate HIV-related outcomes that we found in the literature. We also saw that these sorts of interventions targeted individuals in terms of their behavior, but more importantly, the structural dynamics of gender inequality. We did find evidence on single component and relatively short duration interventions as being successful, but we found much more evidence for multi-component interventions aimed at multiple levels and employing not just the biomedical, but also a social ecological lens. And again, as Sapna mentioned, a lot of the evidence looked at the duration, and we found that longer-term interventions are more sustainable. In terms of who were engaged, women, men-only groups, individual, couples-based interventions seem to be very good at changing harmful gender norms. And finally, we saw quite a few interventions working with women or girls, men and boys, either in mixed sex groups or single sex groups. And these sorts of environments are very gender equitable in these program areas. Next slide, please. In terms of implementing the interventions, we were able to distill a few insights. As Professor Kolsek has already pointed, civil society organizations and the communities themselves, the affected communities themselves, their networks have been key implementation partners. And especially we found the evidence on the role of peers and champions around holistic care, information, and advocacy. At the same time, the evidence shows that government is a critical stakeholder. They need to be engaged. It's very important for them to have capacity in order for interventions to be resilient and sustainable, particularly in the health systems area. Then we found operating at multiple levels through multiple stakeholders and through multiple approaches is important. And incorporating the preferences and the participation of users helps in effective implementation. As regards evaluating the effects of such interventions, they're complex, but we found that it's important to have a clearly articulated theory of change in terms of gender, look sometimes at the more intermediate outcomes, and have intentional designs that enable such assessment. On the policy level, we caution against policies that may have the cobra effect or unintended negative consequences. Instead, it's better to look at policies that advance small incremental changes, the nudge approach. In implementation, sometimes we have to ensure that we're not inadvertently encroaching on human rights and also tailor policies to local context. Overwhelmingly, the politics of change needs to be confronted. This is political work, especially in the current environment. Next slide, please. So I'll just give you one table each on the 5 intervention categories that we sorted the interventions into. Next slide, please. So we also mapped the pathway. So as you can see here, this is a mapping of gender onto the HIV/AIDS care pathway, from prevention to onset of symptoms, to the decision to pursue care, to actual presentation at a health facility, and then taking up testing, treatment, and adherence. On the top half of the slide, you can see certain gender-related barriers that operate at different stages of this pathway. And at the bottom half of the slide, what we've done is that we've mapped the evidence that we found and at what stage of this pathway these interventions were implemented for better effect. You can see some arrows that cross more than one stage, and at the bottom you see a long arrow around multi-component, multi-level, and longer-term interventions. So these are possible gender-related interventions, and this pathway shows you at what stage you might want to intervene. Next slide, please. So here comes the summary of findings around strengthened and more resilient health systems. Next slide. We did find evidence in the primary papers in the various health system building blocks. So, for example, in terms of service integration, we found that some services are often integrated into ANC services or antenatal care, or that gender-based violence services have been integrated onto an HIV platform, and so on and so forth, including with the addition of demand-side financial incentives. And these have the effect of improving knowledge sharing among peers and uptake of HTC, reducing stigma, improving confidentiality, increasing testing, and increasing the use of services. In terms of gender as well, we found that these interventions have shifted harmful gender norms, reduced the acceptance of, the normative acceptance of gender-based violence, increased knowledge and action at individual, couple, and community level. Services have also been modified, for example, through home-based VCT by lay counselors, or through community and peer-based VCT and ART delivery. And here we found health-related outcomes, such as increased uptake of testing and even improved viral suppression rates. On the gender side, it has tended to equalize gender-based inequities that disadvantage men in coverage and increased men's participation in family planning. We found some evidence on service quality improvement, including through male partner involvement. And again, this points to increased uptake of services even later in the prevention cascade and as late as 2 years after the intervention. Next slide, please. On the HRH or human resources side, interventions tended to tackle the stigmatizing and discriminatory attitudes of healthcare providers, but also delivery of certain interventions, for example, a malaria intervention by community health workers, and training community health workers to deliver gender transformative psychosocial interventions. Appropriate training can reduce their opinion-based judgments among health providers, and reduce stigma and depression among people with AIDS, improve disclosure and access. They can also, in malaria, reduce prevalence of malaria parasites and increase the use of different preventive and treatment measures. We found a paper also on medical products and technologies, particularly the women-controlled female condoms. And you can see a range of improved HIV-related outcomes, testing, referral, peer-based knowledge sharing, confidentiality, joint testing by couples, and so on. And on the gender side, promoting reproductive control. Next slide, please. The category of gender norms change was our second category. Next slide, please. This just maps how gender norms, violence, gender-based violence against women and HIV are linked either through direct transmission or in indirect ways through behavioral changes or risky sex and other sorts of risk factors resulting in HIV. Next slide, please. And this graphic shows you the possible entry points using this concentric circles at different levels. So we have found interventions around intervening at the level of individual behaviors. Some examples are shown here, or at the level of communities through changing gender norms and the normative acceptance of violence, or at the legal and policy level, and examples are given here. Next slide, please. This is another graphic just elaborating in a bit more detail how at the community level, at the relationship level, or at the individual level, different sorts of factors, when tackled in a combined way, different sorts of factors related to IPV or intimate partner violence, can in fact have improved outcomes in terms of uptake of services such as prevention of vertical transmission and also improve infant and maternal health. Next slide, please. So what were some of the features of interventions that we saw related to gender norm change, and what kind of health and gender-related outcomes did they yield? They were multi-component, multi-level, and they had elements like participatory training, skills building of couples or same-sex groups. Male partner engagement was an important feature so that you had more gender equitable relationship dynamics and more joint decision-making rather than male-dominated decision-making. Community level interventions like awareness and advocacy or engaging local leaders. And the goals were cross-cutting, not narrow. We saw, again, a range of important health-related outcomes, reducing, particularly around risk, reduced numbers of partners, lowered rates of men purchasing sex, improved knowledge, better and more consistent condom use, better partner disclosure of their serostatus to their partners, improved testing and referral, improved uptake of services, increased male attendance, and importantly, reduced experience of gender-based violence. And we saw improved gender-related outcomes, more gender-equitable attitudes, better communication and negotiation skills, lowered acceptance of IPV, increased recognition of the need for support to tackle this among communities, and within organizations, improved gender sensitivity. Next slide, please. In the third set of interventions, which we're calling social empowerment, we also found compelling evidence. Next slide, please. These interventions were usually, again, multi-component, including educational, policy advocacy, institutional, even structural interventions. But their focus was on exceedingly marginalized groups, sex workers, trans people, women living with HIV, and very vulnerable adolescent girls and young women. And they adopted approaches like organizing, collectivizing, self-empowerment, often through peer collectives and group-based networks, leaders, and volunteers. They tend to be longer term, and they tend to engage multiple strategies and stakeholders. The strategies are around mobilization, legal empowerment, community advocacy, and they intentionally focus on principles like gender power dynamics and gender affirmation. And they also typically have process goals like better decision-making, self-efficacy, facilitating access to services. There were, again, the same sorts of health-related outcomes in this set of interventions, reducing risk factors, improving knowledge, improving service uptake, reduced prevalence, reduced new infections, better testing, increasing the ability of establishments to achieve the goal of no STIs in their monthly screening. These are sex worker establishments, and better negotiation for safer sex. In terms of gender-related outcome, again, we saw improved agency and self-advocacy, and allowing these populations to challenge their own discrimination. We saw a range of empowering outcomes among sex workers that are listed here. For example, using their own strengths and in negotiating and getting better access to legal and informational resources. We also saw increased social support among vulnerable adolescent girls through some of these interventions. Next slide, please. Then we saw the largest group of interventions that we reviewed related to what we're calling economic empowerment. Next slide, please. This was a very striking visual that we found on how economic empowerment interventions actually might result in reduced HIV risk. So you can see that it works through improved self-esteem, confidence, and reduced stress. And you see a range of HIV-related interventions in the last but one column that can be impacted through such interventions. Next slide, please. Again, what do these interventions look like? They typically include gender norms change or social empowerment, which is two groups of interventions that we've already looked at, but what you might consider to be plus economic component. So they have elements of social empowerment and gender norms change, but they also introduce either savings or microfinance or a conditional cash transfer or training or other sorts of income generating activities. These interventions were targeted. They focused on adolescent girls and young women, sometimes on adolescent boys and young men or young people altogether. Some were women-only interventions, and a few were among adults. And they articulate goals like financial independence, but also HIV-related goals. Here again, you see a range of improved outcomes in HIV, increased HTC, contraception, treatment, among different sorts of stakeholders, whether it's adolescent girls and young women, young people, adolescent boys and young men, sex workers, and boys and girls themselves. So the sorts of outcomes that you've seen in other categories, but also increased uptake of testing and treatment, health education services, improved voluntary male medical circumcision, and improved diet quality. These are some of the unique features or unique outcomes in health. And then you saw a range of gender-related outcomes amongst the different stakeholders. They're all listed here, but I'll highlight, for example, adolescent girls and young women, where through their financial independence and savings, they became more self-efficacious, their negotiating power improved, their ability to resist unwanted or transactional sex improved, and you had increased gender equitable attitudes, hope, self-esteem, confidence, reduced spousal conflict, and so on. Next slide, please. The last category and the smallest category of interventions we found was around legal or policy reform. Next, please. Typically, what we found a paper on reviewing the incorporation or the extent of incorporation of gender considerations into national strategic plans for HIV, and we found they talk about incorporating women's practical and strategic gender needs, but most of them considered women in their reproductive roles. There were also policy and legal interventions like training community paralegals to reduce legal and other barriers to access to services, or policies that nudge or encourage behavior change, either at national, institutional, or establishment level, like 100% condom use in sex establishments and so on. And we found that in implementation, policies often combined community mobilization components. And in these policies, you see results in HIV, such as increased visits for antenatal care or HCT testing, their identification as HIV positive, and the use of ART to prevent vertical transmission. You see increased hospital deliveries for HIV positive men with HIV. You see increased HCT even for male partners, better condom use in sex workers, lower STI prevalence among them, and so on and so forth. You also see increased links with HIV and STI screening and testing, post-exposure prophylaxis, and referrals to SRH services. In terms of gender, the community paralegal program created human rights and gender technical working groups to facilitate their coordination, to map programs, and to map gender barriers and gaps. Next slide, please. Now, what does this mean for malaria and TB? Next slide, please. We tried to map, there was a little bit of evidence on malaria, but in addition, we tried to map in the same way as you saw in the HIV pathway, across the malaria pathway, certain gender-related barriers, but also possible interventions that could be applicable in malaria. So just to give you an example around prevention, we saw health education tailored to reduce access barriers, training of CHWs or community health workers to deliver insecticide-treated bed nets and so on, or community-based delivery of bed nets, but also community gender norms change and outreach. In terms of access to services, we have suggested integrating malaria and ANC services and improved male partner involvement, for example. Next slide, please. As far as TB goes, as you heard from Professor Kolsek, there is a body of research around men and men's gender-related barriers in TB by the LIGHT Consortium at the Liverpool School of Tropical Medicine in 4 African countries. Here again, we've mapped the pathway with gender-related barriers and possible interventions. Some of these are taken from evidence in the LIGHT Consortium and others from what we consider might be transferable from this evidence review. So for example, at the level of presentation to at the health facility and getting diagnosed, at that stage of the pathway, we found, as Professor Kolsek has also highlighted, male-friendly clinics that operate in evening hours, or integrating TB screening with HIV or hypertension or diabetes screening, and training healthcare providers to provide respectful care. We also found microfinance, microcredit, and conditional cash transfers might possibly encourage treatment adherence, and completion. Next slide, please. So after that very rapid, hopefully not too rapid review, what did we conclude? Obviously, there is a rich body of evidence we were very happy to find that exists on the ability of gender-focused interventions, not just to improve gender-related outcomes, but also health outcomes. Admittedly, much of this evidence is from sub-Saharan Africa and from HIV and AIDS, especially around prevention and risk reduction. We do have some evidence on how you can have gender-sensitive interventions in HIV through strengthened health system dimensions. Economic and social empowerment approaches, as well as those that affect gender norms, can reduce behaviors related to HIV risk, as well as increase uptake of certain types of services, while also increasing gender equality. Few interventions that have been evaluated seem to focus on law and policy reform, so this is an area for further research. And as Professor Kolsek pointed out, there is a relative dearth of evidence on such interventions in TB and malaria, which means that we still have to develop and test a pool of effective interventions in these areas. But as I've tried to briefly point out, and as our paper points out in greater detail, there are important insights and transferable lessons from HIV that might possibly be leveraged for TB and malaria. Still, we found again that local contexts really matter, and this makes it challenging to identify like a top 10 global list of priority interventions in any of these program areas. Still, what our review does provide is some important insights about the types of strategic approaches, about promising practices and lessons that have been learned in terms of how you design and implement these interventions. And these include having multiple mutually synergistic components, operating at multiple levels, engaging women and men, especially as couples, and importantly, tackling the underlying structural gender power dynamics and inequalities that drive the disease risk and prevalence that we see. Thank you so much for your attention, and I'll turn it back to Joanna.
Thank you so much, Anjana and Sapna, for that summary. I think it is a lot to pack in, but I think you've given us a really good grasp of the findings from the evidence synthesis. And just to let everybody know, there are links that are being pasted into the chat, so you can access both the full report and the summary report. And I do see there are comments coming in, which I hope we will get to and have time for. One comment related to the report, so I'll address it now. The reports are not translated totally into English, French, or definitely not Spanish at this stage, but we do have the summary, the executive summary and findings translated into French. So that is available if you go to the link. So now we have a fantastic group of panelists, as I mentioned at the beginning, joining us, and who will build on, what we've heard from Anjana and Sapna, as well as Professor Kolsek. So let me introduce them all, and then we'll get cracking with the panel discussion. We have Emilomo Ogbe, who is the technical advisor of community rights and gender at the Global Fund, and who was also pivotal and very much involved in this evidence review and work from the beginning. She's a medical doctor and a researcher with expertise in gender mainstreaming, bioethics, sexual and reproductive health, and policy analysis as well, having worked in East, West, Africa and Southeast Asia. We also have Nululeki Zazini, who is the national director of the National Association of People Living with HIV and AIDS, NAPWA. He is also the South African National AIDS Council's Civil Society Forum's deputy chairperson, while being a member of the organization's coordinating committee, co-chair for donor coordination, co-chair of NSP Goal 2 technical task, and the SANAC People Living with HIV sector chairperson as well. So a huge portfolio. And last but not least, we have Andy Seal, who's a cross-cutting HIV expert in WHO's Department of HIV, Tuberculosis, Hepatitis, and Sexually Transmitted Infections. His responsibilities include managing several key multi-sectoral partnerships across the UN system, but also working very closely with civil society as well as affected communities. He has led the development of the 2022-2030 Global Health Sector Strategies on HIV, viral hepatitis, and STIs, and previously worked with UNAIDS and the Global Fund as well. He's also co-funded the UN Plus, the UN staff group for people living with HIV 20 years ago. So welcome all three of you. Thank you so much for joining us today at this launch and for coming in to share your views and your reflections on what we've heard already from Anjana and from Sapna. So Emilomo, maybe I can turn to you to kick us off and tell us why this review is important in the current context, and help us understand, which interventions you think perhaps can improve health and gender equality outcomes.
Thank you, Joanna, for the opportunity to join this webinar. And it's a pleasure and an honor to be here, and also to listen to the wonderful presentation Anjana and Sapna just did as well about the findings. Now, this review is very important now especially because of the current context. We are in a place where we have resource constraints and there's a need for prioritization. And never more has it been important that the interventions we deliver are equitable and person-centered and deliver the health outcomes. Why is this review essential now? It's because it provides evidence-based information on interventions that work, deliver on health outcomes, and also gender equality outcomes. Within the resource prioritization debate, there has been a tension between biomedical interventions and gender equality interventions and what works best and what should we prioritize. Clearly, as you can see from this review process, it's not an either or debate, but it's together. As has been shared as well with the chair and also Angela and Sapna have shared. Interventions work best when they are multi-component and integrated socio-ecological approach and are multi-stakeholder led. So to answer the question as to what interventions work best, the answer is that interventions have to be sustainable. They have to work with they have to be multi-sectoral and multi-stakeholder led. So working not only with community organizations that should lead this approach and should be included in the design and implementation, but national stakeholders have to be involved as well. Interventions that we design cannot be single focused on specific target outcomes, but they have to be embedded in broader national programs and interventions. So while delivering our HIV, tuberculosis, and malaria and resilient and sustainable systems interventions, we have to think about the pathways that Angela and Sapna have kindly shared across the different disease outcomes, and think about how we can deliver evidence-based interventions across those pathways that target equity and gender equality, human rights issues, and also look at service delivery.
Thank you, Emilomo. Mluleki, can I please turn to you to share with us a little bit about how you think these findings resonate or perhaps do not resonate in terms of the work that and insights you've gathered from working directly with communities?
Okay, thanks for providing platform by extending invite to South African National AIDS Council Civil Society Forum. We really appreciate it. I think these findings about multi-component interventions really resonate to us as South Africa. We have seen in the past, just doing a single workshop on condom use or sexual reproductive health rights, it is not enough. We need to combine these interventions with relevant interventions that can make impact in that community. I think we in South Africa, a key issue that is affecting us is HIV and TB more than malaria, because malaria it affects us in border areas and in few regions within the country. At least we are trying to manage it. Looking at issues related to HIV, I have listened very carefully when the latter speak presenter for these findings. Then I related to it on the current situation in South Africa. I think we all understand that South Africa have a huge HIV prevalence and a large ART program in the country. But having said that and appreciating that at least now we have a good life expectancy as people living with the HIV, but there are still some gaps. I think through the programs we are doing in the country, we are able to address these problems. One of the issues that we embark on, it's a HIV community-led program, and TB community-led program, where as communities we are able to gather evidence and try to generate some solutions and share it with our government as part of recommendations, because our role is to advise the government and monitor the implementation of the commitments that our government is making. Yes, as much as we appreciate that the government is giving us some life saving drugs, but there are still some gaps that we see that we think together we can be able to address. For an example, as key population living with HIV, when you go to some facilities, you find out there's a lot of stigma that is attached to those facilities, especially to people that are key population. In the entry point of the facility, security guards, they will judge you because of your sexual orientation, and if you are brave enough, you get through inside the facility. The healthcare provider that is supposed to providing services you without being judgmental is the one who is discriminating and judging you as a person who is living with HIV, who is also a sex worker or MSM or a lesbian. So these are the issues that we think through these programs we're able to address, because we're working very close with our community. The other issue, we have just launched the people living with HIV stigma index at 2.0 in the country. One of the key findings there, we are very disappointed in a way to see that people living with HIV are still experiencing a self-stigma. I think as people living with HIV networks, there's still more that we need to do. And taking from the findings that you have just presented now, I think there are key areas that we can take from these findings to address the problems that we're facing in the country. We were not aware that we still have huge issues related to external stigma in our communities, in particular at a family level, where we expect more support. But through the recent findings of the 2.0 stigma index results that we have launched recently, I think we'll be able to come up to design some clear programs. I think on the issue of inequalities, gender inequalities, I think for me it will be crucial for us to work very close with men institutions so that we can have some sort of dialogues and look at issues that are harmful in terms of gender, so that together we can come up with some solutions so that in future we can be able to address these gender inequalities. In essence, these results, I think it will be important to integrate them on the existing interventions that we are doing in the country, and looking at structures that are already there that seeks to address some of the issues that we talk about today. Thanks.
Thank you so much, Mululeki, for highlighting that. And that point, I think, especially on self-stigma. You know, it's the stigma you face, like you're saying, when you're trying to access services, but then also how you think and value yourself as an individual. And then reinforcing that point about, you know, male engagement. Gender is not just women and girls issue. Men are central. And if we're thinking about power relations, harmful power, toxic masculinities, and how to work together with men to overcome that. So thank you. Andy, can I turn to you? And, you know, from WHO's perspective, how can you help national program managers integrate some of these findings into, you know, the design and implementation of existing or new policies or programs?
Thanks so much, Joanna, and huge appreciation to everybody involved in this work, and also for today's webinar. It's really a critical time to be having these conversations. So WHO works at 3 levels. We have headquarters, where we really focus largely on creating the strategic frameworks and the normative technical guidance that is helpful to countries. We then have regional offices and, of course, our country offices. And all 3 levels are become really active around our critical partnership with the Global Fund. And so what we, and really great to see much of the evidence that's being discussed and shared today is reflected in much of WHO's normative work. And we can really divide that into 2 parts. First of all, we have our strategies, which really take a really comprehensive overview of what's required and really backing up what's been said many times today. Sure, we will focus on the biomedical, but the biomedical has to be understood in a broader context of how to optimize the use of some of those tools. And it's a continuous exploration of data and understanding. So a lot of people today are very excited about lenacapavir as a PrEP and prevention option for HIV. And one of the reasons why people are so excited about that is because we've seen some of the limitations of oral PrEP, particularly for adolescent girls and young women in African settings, where there have been links to violence. Again, building on what Muleleke was just saying around issues of self-stigma and self-censorship, if you will. That happens to all people living with and affected by HIV. So again, just carrying oral PrEP with you for some people feels to be, we've learned can feel to be a risk factor. So having a 6-monthly injection that provides the same level of protection is also an important intervention from a gender perspective as well. When we look at the strategies that we develop, so there are probably two categories. We've got the global health sector strategies, which will undertake a midterm review this year to really reflect what is a very different environment we're facing today with disrupted services, reduced donor funding, and political constraints and constraints on civic engagement. So we have those that really help us with that broader kind of like national strategic planning. And then we have specific guidance that really looks at how we, number one, get key commodities into national programs, whether it's around treatment, testing, or prevention. But then we also have population-focused guidance, and we look at the impacts and the needs of women and girls, key and vulnerable populations, and also building on the other point that Muleleke raised, we have quite a focus also on men, both as the beneficiaries of a gender sensitive and transformative approach, and also, of course, as actors in creating that kind of context that also benefits everyone in society. So again, really, really, really exciting to see recognition of that if we do, if we are serious about gender transformative work, it has whole population benefits around health. It's not just limited to women and girls, and that's critical. The other area that's really part of our current story is, and again, great to see the presentation talking about service integration opportunities around gender-based violence and HIV. But the bigger picture is probably a shift away from vertical programming full stop. So we're talking about primary healthcare. And what that does, it brings in great opportunities, but it also brings some challenges, because we have been fortunate, particularly from an HIV perspective, to build a level of HIV sensitivity which extends to some understanding of gender and power and the need to ensure that all people affected with are able to access services. So there is an understanding, I think, within the HIV world of the need to address access barriers. When we start to integrate services into PHC, some of that interface between communities of people living and affected with HIV and healthcare professionals, those will be new conversations. So people won't necessarily have the expertise, the terminology, the vocabulary to feel comfortable about dealing with some of the issues that can create challenges to access or reassert some of the challenges we've been looking at for decades around HIV that are linked to gender and power and issues around patriarchy, toxic masculinity, etc. So I think we have to continue to be vigilant around this space. We need to continue to look at opportunities and to also make sure that we're referencing back to the evidence base that WHO's role is to continue to track the evidence base, the opportunities that are out there around new innovations, look at it from a comprehensive point of view, and then provide the guidance that countries can use. And we will be very active around GC8. All levels of WHO are working. Sorry, that's the next Global Fund funding round for those who are perhaps not familiar with the jargon. From next week we'll be conducting webinars for countries who will soon be putting their applications together. So we'll be very active around that process, as will some of our partners across the UN system, UNAIDS, UNDP, UNICEF, etc.
Thanks, Andy, for those updates, but also I think reinforcing the point about, really anchoring this within primary healthcare and the importance of that now more than ever in a context of polycrises, funding cuts, etc. Emilomo, can I turn to you, and from the Global Fund's perspective, how can the fund utilize the findings to improve, obviously not just health, but also gender outcomes from, using these gender responsive and transformative interventions?
Thank you very much, Johanna, for that question. I also want to say thank you to Andy for also talking about GC8 and integration. And I think he said a lot already, so I'm just going to be complimenting what he's already mentioned. In terms of how the Global Fund will be using this review, as Andy has mentioned, we're going into GC8 preparation. And there's a push, of course, with the resource constraints to think about effective interventions. Also, as Andy has mentioned, we're going to be prioritizing integration of services into primary healthcare services. So when you look at the review, there have been great examples about service delivery, HIV, TB, malaria interventions, and how we can integrate them into existing services. And some of these interventions are what we're encouraging people through GCA guidance, and also thinking about best approaches to think about these service delivery issues, and also thinking about how can we lose some of our key vulnerable populations, so women, girls, adolescents, young boys and men, and thinking through how we can tailor those interventions to ensure that as they are being put into primary healthcare centers, we don't lose this population. So this is the review and some of the findings in that area, not just for service delivery integration, but also thinking about healthcare workers and barriers to health services are very important. When we think about the impact on gender equality outcomes, we're thinking about, as has been shown through your delivery pathways, the power dynamics, inequality outcomes that exist in the personal space, also in the social, cultural space, in the legal spaces, also influence health outcomes. They prevent the ability to be able to access services, not just for the individual, but for their families as well. Intimate partner violence and gender-based violence has been shown to have impact on health outcomes, physical ability to access services, ability to uptake treatment and to adhere to treatment and services. So in terms of our thinking and in terms of our approaches, we do believe that looking at those client pathways and providing access and recommending some of these interventions that are evidence-based can help us think more holistically about person-centered care. So thinking about how we can support in the multi-stakeholder partnerships, because there's a lot of good work being done by WHO, UNFP and other organizations, to be able to support them, to be able to think through how we can support the people we want to serve across these different places by addressing some of these issues at personal space, looking at effective GBV programs, thinking of how to integrate it into existing service delivery models, and also focusing on more holistic responses, addressing the health outcomes by ensuring that these barriers are also targeted. Thank you.
Thanks. Thanks, Emilomo, for giving us a sense of, just how these findings can be used. Andy, if I can sort of turn back to you briefly. I mean, there are a lot of resources, and in fact, we've shared some of them in the chat. I wondered if you could talk through and share a little bit more about how this research dovetails with additional resources that are available, and also, how this work can feed into other pieces of WHO's work.
Perfect. Thanks, Joanna. So essentially, whenever we develop guidance, we always commission systematic reviews of the available evidence. And so having ready-made reviews like this is just golden for us. And it helps us really kind of like bring this into our thinking when we're looking at, as I said earlier, you know, if we look at something like lenacapavir, we're not just looking at the efficacy of the actual product. We're also trying to understand that service delivery context and environment, and how we can optimize all aspects that are required to ensure optimal service uptake. So we will convene a global a guideline development group that typically also involves members from affected communities, helping to inform what we understand around values and preferences, how different, you know, service adjustments or commodities will be perceived and uptaken by communities, and we bring that into our guidelines, which are then made available to countries to inform their own domestic strategies, their own investment, their own domestic investment kind of like thinking and priorities, but also discussions around donor and partner opportunities as well. So it's a constant cycle, really, of us scanning the evidence to make sure that we are bringing in evidence to our guideline discussions, so that this will be properly considered. So this year, there are a number of things that are happening both at the strategy level. We'll be reviewing what's required in this current context for the next 5 years of the global health sector strategies. We will link to the global AIDS strategy, which UNAIDS has had agreed in December last year. But we'll also be using this opportunity to understand what's new in the environment that we need to reflect in that work. So this will definitely be one of the priority areas of work that I will bring into that thinking, and colleagues will also do the same. Similarly, I've noticed I do have a few colleagues online as well, which I'm grateful to see. And again, these are colleagues who work on a population focus, so they're really just interested in knowing how can we bring in the evidence that's being made available, being analysed and reviewed into our thinking, into our priorities. One final point perhaps I'll make is an extension of this idea of bringing communities into all of our thought processes. This is critical. You know, we can't rely on science alone, and we always have to question, you know, where does the evidence come from? You know, who's paying for it? You know, so we have to question, you know, all of those elements as well, because, you know, I'm not a positivist when it comes to understanding, you know, the available evidence. And so the community engagement piece is critical to all of the processes that are important to this work, as well as an important programmatic focus on its own, if you will. So again, you'll see a lot of focus on peer-led work happening in the context of our guidance, particularly around population-focused guidance, and around community-led monitoring and data, community-led models of care. This is really, you know, very much an area that we're interested in, particularly in this primary healthcare frame that is increasingly influencing how we work with countries to optimize their disease-specific goals and outcomes. So again, huge contribution from everybody who's been involved in this work. It will be useful, it will be referenced, and we're just grateful that we've had an opportunity to engage. Thanks.
Thanks so much, Andy. And I think that point on, you know, community engagement, who's considered an expert, what is considered evidence, you know, really needing to challenge those notions, as well as synthesizing what exists, but being critical of it at the same time. Who is funding it? And I think that was one of the questions that came up from Asha George, which we'll come to. I hope we do have some time left. Just before we open it up for questions, Mululeki, I think on that note of community engagement, you know, how can SANAC Civil Society Forum and other civil society organizations, in your view, use these findings, both for advocacy, but also practice, and you know, bringing up the expertise that communities hold themselves? You're on mute, sorry.
Yeah, sorry about that. I think as SANAC Civil Society Forum, looking at these findings, we strongly support multi-component interventions for sustained impact. I think this means pairing health education with with things like financial literacy and vocational trainings on micro grants, especially for women and young people. It is key for us because they are the ones who are vulnerable. So if you empower them economically, then you will be able to address the challenge. I think the other thing that we can also focus on is capacity building for gender response on healthcare and service delivery. And also to strengthen our CLM programs on HIV and TB and accountability frameworks. And also to advocate for decriminalization and legal reform, to push for review and, and reform of issues that are laws anyway that are discriminatory, like sex work. I think you all know that in South Africa, as civil society, we've been pushing for a decrim of sex work. Because on the other side, as much as Department of Health, together with us, we are pushing and we are more vocal on issues related to prevention. And we encourage sex workers to always use condoms. On the other side, the law enforcement is doing the opposite. They arrest them, they abuse them sexually, they even rob them their money. So we'll make sure that we push for a reform of those discriminatory laws. We will also making sure that transformative community dialogues and male engagement initiatives are taking place in the country using these findings. Thanks.
Thank you. And I think your point about legal reform, you know, that was one point Anjana highlighted in terms of the evidence. It's where perhaps it is the thinnest in terms of examples that have been evaluated of legal reform. And yet we know increasingly in this context, that is an area that is under attack, right? Discriminatory laws are coming back, are being enforced, and a lot needs to be done to really safeguard and push forward and reform them. So thank you. I think those are really valuable points. We do have less than 10 minutes. Maybe we can push by a few. And we do have questions coming in. So maybe what we can do in the interest of time is, if you don't mind, I'll read out or try to summarize all of the questions. There are 4 that I have at the moment. And then we can, if anybody, you know, definitely wants to answer, please raise your hand or unmute. And if not, I'll pick on a few people and ask, Anjana and Sapna included. So please. Okay, so the questions that have come in, a couple have come from Asha George, who I think also has highlighted there was some work in the African Journal of Reproductive Health. There was a special IDRC issue on gender transformative approaches for SRH across Africa. So that's also available, another resource we can share. But Asha asked 2 questions, and one has partially been answered in terms of an authorship analysis and being able to compare authors for our findings with other reviews. So I will ask Sapna or Anjana if you could speak to that, as well as an analysis of funding streams. And I think this comes back to Andy's point about being critical and looking critically at the evidence of who is funding what, and perhaps not funding what very intentionally, as we are seeing. So those are 2 questions. And then a couple from Anju Pandey. One is about anything, you know, have we found anything in terms of the current evidence base that would be an absolute non-negotiable? So in the context where resources are shrinking, you know, are there particular elements that must be protected sort of at all costs to avoid losing effectiveness? And then secondly, and I think a really critical point is, you know, with the discussion, you know, of primary healthcare, but also frontline health functionaries, who, as we know, are mostly women and from marginalized groups, often in terms of lower socioeconomic groups as well, and they're disproportionately burdened. So, you know, how can we make sure that as we're thinking about integrating findings and interventions for HIV, TB, malaria in primary healthcare, that it doesn't simply shift to unpaid or unrecognized work that they take up, and thereby reinforcing gender inequalities. And Professor Kolsek, please, if you would also like to come in on any of those points, very, very welcome. So maybe Anjana and Sapna, I can ask you for the first two, and then we can open it up.
Yes,
Yeah.
thank you so much. And thank you, Asha. It's great to see you here, and also Tanya. And those are amazing questions. Thank you also for sharing the link of your scoping review on these very questions around sexual and reproductive health research in Africa. I think this would be an amazing spin-off piece of analysis for this evidence review that we've done. We didn't have, we didn't look at that systematically, but just impressionistically. I think what I can say is that many of the primary papers were produced at least with co-authorship of people in the countries where the interventions took place. In several cases, these are well-known interventions like DREAMS and Stepping Stones and so on, where the funding agencies, of course, may have funded the research. But I think this is something to go back to and try and nail down. Encouragingly, some of the research that we saw on social empowerment approaches, especially that those interventions that involved sex workers, those were often sex worker, at least the interventions were sex worker led, designed and implemented. To what extent they were, they were engaged in actually doing the documentation and the research part is an important question to look at. And I might touch on Anju's two questions also. We did try to mention in our conclusions that it's hard to come up with this list of top 10 or highest priority or even non-negotiable, but we did see some recurring patterns. And I think that those are the sorts of messages we've tried to highlight in the conclusions, namely that this is not simple, straightforward, there's not always a linear link. We saw how many interventions might operate over a long duration with multiple self-reinforcing or synergizing components and with a range of stakeholders or approaches. Now, admittedly, we may not have the luxury for that kind of intervention in today's environment. So we did also document some much shorter duration and quick win type interventions. I recall a couple, especially in the economic empowerment space, but also in the gender norms change space. What I would say about non-negotiable is the intentionality that when an intervention is formulated by a disease control program and purports to be gender focused, then there need to be design, implementation, and evaluation elements that are intentional about the gender dimension as much as they are about the disease element. So I think that would be sort of my non-negotiable. And when you are intentional about what is it around gender dynamics, gender power dynamics that you're trying to change, then I think you're forced to confront not just individual behaviors, but the structural factors. And these structural factors are harder to influence. As we say in the report, they're political, but they're what makes the difference for sustainability and impact. Thank you so much. Oh, one last thing on primary healthcare and women health workers and women's work burden. We found some interventions where work burdens had changed at home as a result of improved gender dynamics. So that's promising. And we also saw community health worker-led changes and interventions. So I think there's an important word of caution around that. But there were also, in some of the systematic reviews, some findings related to nurses being able to take on tasks that doctors have. So task shifting is an important part of the solution, I think. Over to you, Joanna.
Thank you. Does anyone else want to come in response to some of those questions?
Joanna, can I comment quickly?
Please.
So I would like to respond to the question on funding and to the primary healthcare workers, community health workers. So when it comes to question of funding, of course, we saw a pattern that certain intervention like economic intervention appeared more when it comes to searches. And this is not specifically confined, let's say, to the HIV or TB related intervention, but there is a larger pattern. That's how politicians or other things that you economically incentivize, and the things might work for the short term period. So we are also seeing that economic incentives work in other domain. So I'm not sure whether that was the intention behind funding for short term gain, but that has been a larger pattern across multiple sectors where economic incentives get prioritized over other thing. And that could have been one of the reasons why we found multiple articles where economic empowerment was one of the major outcomes. So that could have been one of the reasons. I'm just guessing based on what is happening in other domains. The other question on overburdening community health workers, yeah, of course, that's the thing. But we are also now increasingly witnessing resistance from the community health workers. So and in India, we have been witnessing a lot of protests from different parts of India and also in other South Asian countries. So again, it's not just that the government will dump onto them. Of course, government will try to dump onto them because this is the pattern over decades. But I think now increasingly there's a lot of resistance from the community health workers. So it's an interesting thing to look forward to how the system evolves over time. Thank you.
Thanks, Sapna. Mululeki?
Okay, thanks, Johanna. I think for me, taking from these findings, I want to encourage communities to use these findings as an opportunity to develop programs that seeks to respond to these findings, because it is evidence-based for me. I think we need to remind each other that health is a human rights issue. Health is a human rights issue. Then for issues related to non-negotiable, I think communities must remain in the center of response. In anything, we need to make sure that communities remains in the center of response. That is non-negotiable. Thanks.
Thank you. Emilomo?
No, Mulilaki, I just want to thank you for that closing comment. Of course, communities need to remain at the center. And I just wanted to add to that in terms of non-negotiables. Now, that's a very important question you've raised, especially when we're thinking about prioritization. And the question is, the answer, I think, from our side is that it's a very complex question. I do think that that will depend on different contexts, different resource constraints, and the national government and the community setup in each country. But I think the non-negotiables should not just be at the intervention level, but it's also at the approach level. We are pushing for that interventions within a country, the decision on what to prioritize should be informed by evidence. And that's where something like the evidence review plays a key role in that, as well as research in integrated equity, human rights, and gender assessments. Now, we've asked that this doesn't need to be done just because, but that it's also linked to national strategic planning processes that have been done in the last 5 years. And I think that prioritization exercise has to be done in a multi-stakeholder way. So as Leki has kindly raised, you have to bring the national stakeholders and communities together to think about what needs to be prioritized in community dialogue processes, thinking about the funding envelope the country has within the investment that's provided, as well as in its national priorities, and thinking about what works. Because it's easy for us to talk clearly about you should do this, you should do that, this should be prioritized in a certain context, but that would be so different, country by country, region by region. So we would like to prioritize the approach, evidence-based, participatory, multi-stakeholder, thinking about what fits into national strategic priorities, and ensuring that it's ethical. Because if we do an intervention that's not participatory, doesn't think about these barriers, we have the danger of exacerbating existing inequalities and not actually delivering on targeted outcomes. But I do encourage everyone to do that prioritization approach with those key approaches and a focus on delivering quality, person-centered, equitable care. Thank you.
Thank you so much, Emilomo. We are almost 10 minutes over. I don't know, Andy, if you had a burning point. I know you also put it in the chat, but please, maybe a last comment and then I'll
Sure.
wrap up.
No, thanks. And I think I made the comment earlier. I think even as we look at some of the new opportunities that are coming through, and I use lenacapavir as the example, it's really critical that we look at this beyond the biomedical kind of like commodity. This is an opportunity for us to really think about what's engaged in the delivery of this. How do we target? How do we think? What information do we need? What insights do we need, and from who? And great to see that health workers have been recognized in this context as part of that broader community. It's where we have that interface between affected communities and health workers that I get very excited about, and also health policy people myself, frankly, as well. I really find that this is where you find the energy, the insights, and the excitement. And final point would be, I really quite like the work around systems complexity and systems thinking. And I think this is where we need to be really thinking about what are the positive and negative feedback loops when we make adjustments, and how can we be on top of that continuously? And this really requires continuous kind of like exploration of theory and practice and evidence and practice. Thanks so much for this session today.
Thank you so much, Andy. I think that's a great way to end. Just to thank everyone once again, Professor Kolsek, thank you for that, fantastic opening, and I think really setting the stage, Anjana and Sapna, for doing an incredible job summarizing a lot of detail in a very short time and giving us all a taste of the report and the findings. And to Andy, Emilomo, and Mululeki, really fantastic panel. I think you've brought complementary perspectives, but different perspectives, and made really critical points. I won't try to summarize them all. I'd also like to thank our communications team, who have been working in the background, as well as an incredible interpreter, Philomen, who has been interpreting simultaneously as we have been talking. So thank you so much, everyone. The resources, the link to the report is available in the chat. It is also going to be a peer-reviewed publication coming out shortly in BMC Public Health. I think there's the pre-publication version already up, but we will publicize that more. And just to say, on this point of legal justice and legal reforms, we have our next webinar on the 11th of March. So that's going to be a conversation with Geeta Sen and Sarah Hossain, discussing gender justice and legal reforms in the current context. So do join us then as well. And just to say a huge thank you once again to everyone.
Thank you so much. Bye-bye, everyone.
Thank you. Bye. Thank you.